Nowadays, endovascular therapy for below the knee arteries has been widely recognized as an effective therapeutic strategy for limb salvage. However, many physicians seem to have some difficulties in understanding what exactly is the appropriate technical endpoint in below the knee interventions. Angiosome concept, which Dr. Ito from Cancer Rosa Hospital has reported, could be a more reasonable answer for such discussion, of course. However, is this angiosome concept true for patients? In daily practice, we face many patients who have diseases not only below the knee, but also below the ankle level. Dr. Kawada from National Cardiovascular Center in Japan categorized these pedal arteries into three groups. Type 1 is a patent, type 2 is incomplete, type 3 is absence of the pedal arch. According to his report, absence of pedal arch is an independent predictor for delayed wound healing. Why absence of pedal arch became such serious problems? Okay, I came up with some reasons. First, as you can easily imagine, the angiosome of type 3 patient is already destroyed, and so that unless you revascularize these occluded arteries, you could not achieve a direct flow towards the wound. And another reason is that the type 3 patients normally have poor runoff. And because of this, even the upper below the knee arteries are nicely treated, slow flow or no flow phenomenon could be still occur at the distal end. And furthermore, this poor runoff give negative influences of the treated upper below the knee arteries, and therefore leading to a lower rate of limb salvage. Do you have any solution for these situations? Today, I'd like to propose a new strategy concept for limb salvage. It's called the pedal arch angioplasty. I'd like to show a case in which I performed the pedal arch angioplasty. Case is a diabetic female, 80s diabetic female with multiple non-hydroxyl in her toes. Control angiogram disclosed very severe isolated below the knee region. There are no pedal arch lung opacity except for the metatarsal arteries. First, we try to recanalize the occluded anterior tibial arteries with antegrade. However, unfortunately, antegrade wide went into the subintimal space. It did not work well, so we decided to perform a retrograde access. However, there are no pedal arch. Her pedal vessel is completely occluded. Conventional pedal puncture was impossible. Then we decided to puncture her first metatarsal arteries. Fortunately, puncture was successful, and we can insert a retrograde guidewire very smoothly. After the retrograde guidewire insertion, we finally crossed the guidewire with wire landing techniques. After the guidewire crossing, we dilated AT and DP with tapered balloon. They successfully recanalized, but flow was delayed. Therefore, we tried to cross the guidewire to the occluded her pedal arch. After the guidewire crossing, we sealed the whole of her pedal arteries with a 2.0 mm long balloon. We performed the pedal arch angioplasty. After the pedal arch angioplasty, the flow was sufficient. The final result was very satisfactory. Her wound was going to be cured. This is a take-home message from my presentations. Perceptions on what is the appropriate technical endpoint in below the knee interventions have changed dramatically from time to time. One time, one surgical method delivered from the distal bypass surgery was considered to be the best strategy. However, then, a new concept was introduced, and we thought it was the most reliable strategy for limb salvage. However, now we face many patients which even angiosome concept might not work. In such cases, pediatric angioplasty was a very important option for your limb patients or limb surgeries. Thank you very much for your attention.
Yeah.